Good evening, all. I welcome you all to the webinar on quality improvement in healthcare systems organized by Society for Nursing Practices and BioLeagues Worldwide. Beginning with a warm welcome, me, on behalf of a Society for Nursing Practices, I would extend my warm welcome to our speakers and the participants who have joined the forum, beginning with the overview of our Nursing Association. SFNP, Society for Nursing Practice Association, is one of the non-profitable professional associations operating under Technorate Research and Development Association, meant for research and development in the field of nursing science, nursing education, and healthcare. SFNP is a paramount body which has brought revolution and sustainable development in the field of nursing, neurology, and healthcare. Is a professional association caring for people. SFNP is an international forum for allied health professionals, nurses, nurse practitioners, research scholars, scientists for sharing knowledge and innovation in the field of allied health science, nursing science, and healthcare. SFNP aims to bring together allied health science nurses and healthcare community to encourage intellectual development and providing opportunities for networking and collaboration. About BioLeagues Worldwide, as a globally recognized professional organization operating under the Technorate Research and Development Association, BioLeagues Worldwide is dedicated to the out advancement, proliferation, and furtherance of research and development activities in the field of medical science, pharmaceutical science, life science, and healthcare. Quality improvement in healthcare systems. Quality improvement is the framework used to systematically improve care. Quality improvement seeks to standardize process and structure to reduce variation, achieve predictable results, and improve outcome for patients, healthcare systems, and organizations. When healthcare leaders get goal for their organization, such as preventing patient falls, or a medical system aim to lower opioid use after surgery, they use a process called quality improvement. But what is quality improvement in healthcare really about? Quality improvement is a systematic approach that is guided by data to improve the quality and safety of healthcare delivery, said Deborah Sowell. Quality improvement mainly focused on care that is safe, timely, effective, efficient, equitable, and patient-centered. Improving healthcare quality and safety is a growing focus for the nursing field and healthcare system as a whole, as medical institutions aim to achieve efficiency, reduce healthcare cost, and ensure health quality patients' outcome. Here we have our expert speakers who will deal with the various aspects of quality management in healthcare systems. If you want to play a valuable role in the future of a patient care and safety, then exploring job in healthcare quality improvement could be right for you. I would like to welcome our keynote speaker, Mrs. MIKKI ma'am. Mrs. MIKKI ma'am is currently working as Associate Professor at RUFAIDA College of Nursing, JAMIA, HAMDARD. She has multi-talented career in the field of nursing with an experience of more than 18 years on nursing services and education. She's currently pursuing her doctorate at JAMIA University. Her career has been through from staff nurse, clinical instructor, tutors in nursing faculty. She has published uncountable number of research papers under national and international journals, which is his area of focus. She has also organized many conferences, international and national conferences, and webinar, and presented her research paper in it. She is specialized training in newborn care and quality improvement, neonatal resuscitation program, etc. She is currently holding the honorable membership position in Trained Nurses Association of India, Indian Association of Neonatology Nurses, Society of Midwives in India, National Research Society of India, and Society for Nursing Practices. She is holding a position of editorial board member in Journal of Nurse Midwifery and Maternal Health, National Journal of Pediatric Nursing, and International Journal of Nursing and Midwifery Research. Welcome, ma'am. Dr. SHERIN SARA KOSHY, ma'am. She is a professor in the Department of Obstetrics and Gynecology at Kim's College of Nursing, Kerala. She has an impeccable experience in the field of nursing education. She has also organized many conferences, international and national conferences and webinars, and presented her research paper in it. She has published her remarkable research finding in international and national journals. She's currently holding the honorable membership position in Trained Nurses Association of India, Society of Midwives of India, Nursing Research Society of India, and Society of Nursing Practices. I welcome Ms. MIKKI, ma'am, Associate Professor. Please,
hello, hello, ma'am. Am I audible to you?
Yes, ma'am. You are audible to me.
Okay. Thank you so much, ma'am, for such a elaborative introduction.
Most welcome, ma'am.
Thank you so much. So now I'm going to share my screen.
Yes, ma'am.
Is it visible to all of you?
Yes, ma'am, it is visible.
Okay, thank you so much. So today, as we are gathered here for a webinar, and the topic for the webinar is quality improvement in healthcare system. So when we just talk about the quality, it is very important when we're dealing with the patient, when giving care to the patient. So at least patients should have safe care and quality care. So we're just going to discuss about the quality care. So before starting the quality, first of all, we should know what is the meaning of quality, a high level or of value and excellence. So which is a meaning by Merriam-Webster dictionary. Another definition of quality is the optimal balance between possibilities realized and a framework of norm and values. This definition is given by Harton in 2003. Again, what is quality care? So when we just talk about the quality, then first of all, we should understand the quality, and then we should able to understand what is quality care. So quality care is a fitness to use by customer. So this definition is given by Joseph Duran, and conformance to requirements, Phillips Crosby. And another definition, it is a complete satisfaction of the needs of those who are in most need of health services for the lowest organizational cost within the given limit and guidance, higher administrative bodies, those paying. So this definition is given by Orbit in Ritonja in 1998. So basically, quality care means we are able to give a care which is satisfactory, and cost of the care should be less. So this is called quality care. This refers to the degree which healthcare increases likelihood desired health outcome and is consistent with current professional knowledge. So this definition is given by Institute of Medicine in 1990. It takes into account into three factors. First factor is variability of the achievement of quality. Each time care is rendered, healthcare cannot guarantee the attainment of outcome that clinicians and patients expect. Scientific evidence and professional standards are crucial in defining. So basically, these three factors are there, which are very important when we're just talking about the quality care. Now, the end goal and ultimate recipient of any effort towards the quality of healthcare is patients. So whatever care we are providing, whatever care we are giving, so the end product or the end receiver is a patient. So we can assess, we can make it out whether patient is satisfied, patient's comfortable, and we can make it out the patient is happy with the care. So basically, whatever care we're providing, So the end recipient is a patient. In 19th century quality of healthcare thinking, Dr. Edwin Kedwick in 1842, he reported unsanitary conditions in communities and the lack of public health professionals to provide quality services. He recommended the creation of guidelines for the training of the public health workers. So in 1842, he observed because of the unsanitary conditions, the person, they are not able to have a good health. Dr. Lemon Shattuck, at about the same time in the United States, published a similar report on sanitary condition in Massachusetts. Florence Nightingale, a little over the decade later in 1854, then serving as a nurse in the Crimean War, introduced the idea of quality care in army hospitals and posited that adequate nursing care to the wounded soldiers would decrease the mortality rate among them. So basically, in 1854, Florence Nightingale, she worked in Second World War, and she had served the wounded patient, and she has found that by giving a care, by giving a proper care to the soldiers, they can improve their health. This war was the first time that relationship between the quality of care and positive outcome was established. So it was established and it was mentioned by WHO in 2001. In 1999, Joint Commission on Accreditation of Healthcare Organization, US, published experts from her book as Florence Nightingale Measuring Hospital Care Outcomes. Now, why quality care is important? Jonas and Rosenberg in 1986 have identified 4 broad categories which explain the need for the quality care. Hippocrates, he said, first, do not harm. So if we are not able to give the care, so at least we should not harm to the patient. Patient should be safe. Patient should be in safe hand. And second, the social and humanitarian motivational to use resources for the good those in need. Then professionalism and survival. So these are the 4 factors which are mentioned by Jonas and Rosenberg in 1986. Now, why quality care is important? That it is a tougher competition. Frequent medical errors are there. Rising costs, limited health expenditures, rising demand, limited health resources, concern with the variation in healthcare outcome. So we are nowadays, if we see the healthcare, so we like in scenario, there are so many competitions are there, and competitions are so tough for the quality care. And few things we can make it out. Medical errors are there. So these can be preventable, and these preventable thing can save life of so many patients. Then we also aware that nowadays the cost of the care is very high. It's very expensive. So we should try to give the care with minimum cost. And rising demand and limited health resources, as we have demand is quite much and we have limited resources, so we are not able to fulfill the demand of all the people. Then concern with the variation in healthcare outcomes and cost. So these things are there. Then quality healthcare, whatever delivery is seen at the patient end or from the provider organization perspective, start for 2 principal actions. When we're just talking about the quality care start, so where the quality care start, so basically it is start in the hospitals or healthcare centers, and it is mainly depend upon 2 principal action. First is decision making, and second is performance action. Now decision making is what? Selection of the most appropriate health intervention. So whenever patients having any problem, any health conditions are there, so first of all we have to choose which is an appropriate health care intervention for the patient. Performance action, it should be effective, it should be efficient, it should be timely application of the selected intervention. So these factors are there. Then healthcare customers. When we just talk about the healthcare system or quality healthcare, so we have 2 customers are there in quality health setup: internal customers and external customer. Staff and employees and funders are the internal customers, and external customers are patients, payer of healthcare, and contractors. So basically, who providing the care to the patient, they are internal customers, and who are receiving a care from the healthcare team member, they are external customers. So basically, you can see this diagram. Patients, if we are just giving a quality care to the patient, so it should be safe, it should be efficient, it should be effective, it should be appropriate, it should be accessible, patient-centered. So we have provider, we have setting. So we should try to give the care which is safe for the patient, which is efficient, effective, appropriate, accessible, and patient-centered. Now, dimension of quality healthcare. Most clusters of quality indicators were and often continue to be the comprise of 5Ds. So previously, when they just talk about the healthcare outcomes or evaluations, so 5Ds used to mention these are death, disease, disability, discomfort, and dissatisfaction, rather than more positive component of the quality. So previously, what happened? They try to see the outcome by these 5Ds. So these Ds were death, disease, disability, discomfort, dissatisfaction, rather than more positive component. Now, most common institution of medicine to identify the component of quality of care in 21st century is centered on the conceptual component of quality rather than the major indicators. So quality care is safe, it should be effective, it should be patient-centered, it should be timely, it should be efficient, and it should be equitable. So Institute of Medicine, they have given the emphasis on the quality care component. So they have emphasized these indicators that whatever care we are giving to the patient, it should be safe to the patient, it should be effective, it should be patient-centered, timely. Patient should not wait for a long time, and it should be equitable. The safety is the foundation upon which all the aspect of quality care build. So basically, when we just talk about the quality care, then safety is the first most step in which we can provide the patient, and the patient can have quality care. Then dimension of quality health care. The work of American Academy of Nursing expert panel on quality health focus on the following positive indicator of the high quality care that are sensitive to nursing output, input, achievement of appropriate self-care, demonstration of health promoting behavior, health-related quality of life, perception of being well cared, and symptoms management to criteria. So these are the dimension of quality health care. Now, Institute of Medicine, they have given the aims of the good quality care. So as I had discussed earlier also, so these 6 aims are there. First is safe care, effective care, patient-centered care, timely care, efficient care, and equitable care. So now what we understand by the safe care, that we have to avoid the injuries to the patient. Whatever care we're giving to the patient, then patient should not have any harm, patient should not have any injury. And effective care means providing care based in scientific knowledge. So whatever care we are giving, it should be based on scientific knowledge. All the care we are giving, it should be scientifically or evidence-based proof. Patient-centered care, providing respectful, responsive care that ensure the patient values, guide, and clinical decision. So we have to respect each and every patient, and we have to take care of all the patients, their values, their decisions. Timely care, reducing wait for both recipient and provider of the care. So when patient, coming to the health center, so patient should not wait for a long time, or so it should be timely care. Efficient care, avoiding waste. Then equitable care, we have to make sure that quality of care does not vary because of the characteristics such as gender, ethnicity, socioeconomic status, or geographical location. So these are the aims which is given by Institute of Medicine in quality care. Now, PhilHealth, they have given certain dimension for the quality healthcare. So these aims almost same with the Institute of Medicine. So they have described the aim. It should be safety, it should be effectiveness, appropriateness, consumer participation, accessibility, and efficiency. So these, aims are given by PhilHealth. So safety means cover safety issues and phenomena like adverse event complications and sentinel events. Major objective of any health service provider should be safety to the patient. So whenever we're giving care to the patient, we should make sure that we have to provide a safe care to the patient. Effectiveness, treatment received will produce major benefits. So whatever treatment we are giving to any particular condition, disease condition or problem, then patient should have some benefit, patient should have some improvement. Appropriateness, it is about using evidence to do the right thing to the right patient in timely fashion. Then consumer participation, develop mechanism for gathering members' input, assessing their satisfaction level, and service provider. So basically, whatever care we are planning to the patient, so it is not only just the health team member, they have to plan the care. We also have to involve the patient in the patient care. Accessibility, support access to health services on the basis of patient need, irrespective of geography, payment group, ethnicity, age, and gender. So basically, it should be accessible to all the people and without any bias. Efficiency, measure, minimize inappropriate resource input and allocate resources to serve which provided the greatest benefit. So basically, whatever resources we required in the care, that we have to use, and we have to, avoid unnecessary wastage of the resources. So these are the aims of the quality healthcare. It should be safety, effectiveness, appropriateness, consumer participation, accessibility, and efficiency. Dimension of the quality healthcare. So these are the dimension of quality healthcare. So whenever we are talking about the quality healthcare, so we have to see all these dimensions should be there. Now certain cross-dimensional issues are there. So these cross-dimensional issues are competency, information management, continuity of care, evidence-based medicine, education, training, and accreditation. So these competency and descriptions, 3 levels of competencies to be addressed: organization, multidisciplinary care team, and individual competencies. Information management, providing accuracy, appropriateness, completeness, analysis of the healthcare data if judgments and clinical quality are to be made. Then continuity of the care, whatever care we're giving to the patient, it should be continue and refer to the extent to which an individual episodes of care is coordinated and integrated into overall care provision. Evidence-based care, emphasize the use of evidence-based medicine in making decisions relevant to care provision. Education and training, to successfully implement this framework, organizations shall carry out a well-planned education program to all the stakeholders, set priorities for the development of clinical practice guidelines and other quality improvement activities. Then last is accountability, access and organizations compliance with set standards. So these are the dimension by PhilHealth. Now, when we just talk about the care, quality care, then we must able to understand what is standard. Okay. So what is a standard? A journal agreement of how things should be, performed. So this is called a standard. This definition is given by 1970 by Wendell. Delineate and best possible condition that should be exist in the organization for it attain a quality performance. So when we just talk about the quality care, after the aim of the quality care, we should understand what is standard care. Set maximum achievable performance expectation for activities that affect the quality care, like compliance with the patient pathways, which emphasize the interference between the management unit. Then what is the standard of care? So these are the skills, learnings commonly possessed by members of the profession. So whenever they are giving a care to the person, so they have to make sure that they are giving a standard care. These are the used to evaluate the quality of care nurses provider and therefore become legal guidelines for nursing practices. What is nursing standard? It is a valid definition for the nursing quality, include criteria which can be used to assess efficiency. So basically, first of all, we should give a quality care. It should be safe. Then we have to see the patient should have satisfaction, patient should have comfort, and then we have to give the standard care. And after that, we should take care of the nursing standard. Then why is standard important? Outline what the profession expert to its member, promote guidance, direct professional nursing practice, important for self-assessment and evaluation of practice by employer, client, and other stakeholders. So we should have some set standards are there. So on the base of that, we can make it out that we are giving the care according to the standard, provide nurses with a framework of developing competencies. So they have framework for developing the competencies, aid in the developing a better understanding and respect for various complementary roles that nurses have. Then classification of the standards, it can be of 2 types of standards: internal standards and external standards. Internal standard for the employees or health team member who are giving a service to the patient, providing care to the patient. So these are job description, education, expertise, institutional policies and procedures. Now external standards: Nurse Practice Act, professional organization, nursing specialty practice organization, federal guidelines. Now, assessing quality healthcare. Now, how can we assess that we are giving a quality care? It is very important to do the evaluation. So there are so many ways are there. By doing the evaluation, we can make it out that the care which we have given to the patient, it is standard care and patient safe care to the patient. So first we have to set a goal for that. The desire for situation targeted by performance improvement programs. So whatever we have target, we have to make a goal that what kind of care we are going to the patient. Then standard statement of expectation for the input, process, behavior, outcome of the health services. They can effectively limit variation by defining what is expected from the organization in its daily activities. So we have to maintain the standard that what kind of care we have to give and which is expected from the organization in daily activities. Criteria: lay out the specific action that need to be done to meet the standards, are developed to specify the attribute of structure, process, outcome, component of the care. So we all have to think about the criteria. And then indicator. These are the measurable variable or characteristics that can be used to determine the degree of adherence to the standard and achievement of the quality goal. So these are the assessment of quality care. By this, we can make it out that we are giving a quality care to the patient. So first we have to set the goal, then we have to make the standard, then we have to make a criteria, and then we should have indicator. On the base of indicator, we can evaluate that what kind of care we are giving to the patient. Now goal. Suppose we have to recruit the healthcare member in any health setup. So recruitment is their selection, appointment of the staff, complying with statutory requirement, are consistent with the organization human resource policies. Standard, all services are provided by the staff member with appropriate qualification, experience, and training. So whatever health team member, they are providing care to the patient, so they should be experienced, they should be qualified, they should be well trained. Criteria: all the doctors and nurses, midwives providing clinical care, current license and document evidence of appropriate training and experience. So they should have registration, they should have documentation. All administrative, business, and technical service staff have current license and document evidence of appropriate training and experiences. Indicator: percentage of staff with current licenses. So these are the example of about how can we provide the care or quality care. Now, Avedis Donabedian described the relationship between the structure, process, and outcome, and posited that an organization with the right structure and process in place will produce a better care. So suppose if we having a good health team, if we have a good health team member, we have human resources, but we don't have a good structure, so we are not able to give a quality care. He adds that quality assessment aim to determine how successful providers have been able to do their work. The quality monitoring generate constant surveillance, which facilitate early detection and correction of any deviation from the standard. So while giving the care, continuous evaluation is very important. By doing an evaluation, we can make it out that where is the gap, where is the lacking, so which we can overcome. Now, Donabedian's model of quality care assessment, he has mentioned quality care assessment into three aspects: structure component, process component, and output component. According to the Donabedian model of quality care, so how can we do the assessment of the care? By structure component, what all material, human resources we are available in the institution or organization, process, medical, non-medical action, whatever care we are giving to the patient, that is our medical care, non-medical care. Then outcome component: physical, psychological, social effect of the care. So what is the outcome of the care? So that we can make it out by these three components are there. On the base of that, we can make it out the quality care assessment. Now, 3-tier level of quality nursing care is there. So level 1, level 2, level 3. So level 1 means all patients are cared for according to the routine care, right? So in level 1, acceptable nursing care we are giving. That means all the patients, they are able to get the routine care, the basic care they are able to get. Level 2 is comparatively good nursing care. Nursing is planned, but the patient is not directly involved in planning and assessment. So nursing, they are planning the care, but they are just planning with health team member. They are not involving the patient. Now, level 3, excellent nursing. Nursing is planned and assessed together with the patient. His relative, the patient is an equal partner in the nursing process. So these 3 levels are there, in which we have discussed level 1, acceptable nursing, level 2, comparatively good nursing, level 3, excellent nursing. So in level 1, all the patients, they are care with the basic or routine care. Level 2, team member, they are planning for the health care, but they are not involving the patient. In excellent nursing care, they are involving the team member as well as they involving the patient as well as the relative. Now, what are the nursing sensitive quality indicators? These are those indicators that capture care of its outcome most affected by the nursing care. And this definition is given by American Nurses Association. Then 10 nursing sensitive quality indicators are there, which we can see in the acute care setting. So it should be mix of registered nurse, registered midwife, and unlicensed staff caring for the patient in acute care setting, total nursing hours provided per patient care, pressure ulcer, patient fall, patient satisfaction with the pain management. So when these are the 10 nursing sensitive indicators are there, which also reflect the quality of care. So whatever, health team we have registered people as well as unlicensed people, and we have to see how many hours of care it is provided by the nurses, and we can make it out by pressure ulcer. If the patient is having pressure ulcer, if the patient they have fall injury, so it shows the safety and quality of nursing care, the patient satisfaction with pain management, and how much patient relief from the pain. 6 point, patient satisfaction with educational information, patient satisfaction with overall care, patient satisfaction with nursing care, nosocomial infection, nurse staff satisfaction. So these are the sensitive indicators are there, which can give the evaluation of the nursing care, how nursing care is providing in a particular health organization. Now, improving the quality of healthcare. How can we improve the quality healthcare? So these 4 steps are there. First, quality control, quality assurance, quality improvement, and total quality management. So when we have to give a quality improvement care, or we have to improve the quality care, so these components are very important. Quality control, quality assurance, quality improvement, and total quality management. So what is quality control? Involve inspection of finished product aimed at the detection of the deviation from their predetermined design. So if we are able to give the care to the patient, we can make it out if there is any deviation, if there is any lacking in the care. So that can be checked by the quality control. These deviations were considered error or defect. Defective products were either reworked or discarded. So if we have found that any particular care is not given according to the design pattern or anything which is so this will consider as an error or defect. So these either reworked or discarded. However, it soon became apparent that quality control was expensive and wasteful process. This is very apparent in healthcare. Now, what is quality assurance? This is a perspective looks at the prescription of the set of preventive activities to ensure the quality of the finished product. Then these activities evaluate whether the process of planning, execution, delivery, and maintenance of goods and services are being performed according to the stated design. So basically, quality assurance, like it is the evaluation of the patient care. After giving the care, we can make it out that our planning, execution, delivery, maintenance of goods and services are being performed according to the stated design, or some deviation is there. Then quality improvement. It is a combined and unceasing effort of everyone: healthcare professionals, patients, their families, researchers, prayers, planners, educators, to make the change that will lead to better patient outcome, that is health, better system performance care, and better professional development. So quality improvement is an unceasing effort which will be continuous. So we can make it out where we have lacking, where we have problems, so we can make out this lacking or gap, so we can work on it. Now, what is quality management? Quality management, the name implies management oversight the material quality healthcare. So this definition is given by Donabedian 2003. When the pursuit of quality include the perspective of internal staff, founder, external customer. So we have, when we just talk about the quality management, so we have include perspective from internal aspect as well as the external aspect. Internal aspect will be the staff and the funders, the health team member who are providing the care. So they are the internal perspective, and external customer, patients, and who are getting health services, they are the external customers. So this is total quality management. Total quality management being client-driven, participatory and process and team-oriented. It calls for flatter, less hierarchical organization where manager directly lead teams built around principal work and process. So this definition is given by MIKKI in 1995. In a hospital setting, this would mean organizing patient entry, care, discharge team, which group composed of doctors, nurses, and support. So like whenever patient admitting in the hospital, so the care start on the same time. So it is not only done by a particular person, it is a team member or organization they are giving a care. So it will start from the entry of the patient stayed in the hospital, the care which we have provided the care to the patient, as well as when patient is discharged. So what all care has to be given, what all education has to be given, with the team group composed of these are doctors, nurses, and support staff. Now, other features of total quality management, it should be, it is given by MIKKI in 1995. Decentralization, workforce, integrated data system, long-term and quality-oriented relationship, training is integrated with quality and productive goals. Quality is measured by client needs and process improvement. Quality reflects continuous improvement and client satisfaction. Now, when we just talk about the quality care, we have 3 dimensions of quality care. So these 3 dimension: professional, technical aspect, interpersonal aspect, and social aspect. Now, what are the professional technical aspect? Accuracy and diagnosis, efficiency, efficacy of the treatment, excellence according to the professional standard, necessity of the care, appropriateness, continuity of the care, and consistency. So these are the professional technical aspects are there, which we have to observe in the health team member. Then second, we have interpersonal aspect. So these are the patient satisfaction, acceptability, time spent with the provider, attitude of the provider and staff, and amenities. Then third aspect is a social aspect. So it is a efficiency and accessibility. So whatever care we are providing in by the organization or any institution, it should be accessible to the patient. Now we'll be discussing about the principles of quality. Quality improvement is a journey of many small steps. Success is achieved through meeting the need of those we serve. Most problems are found in process and system, not in the people. Actions are based upon the accurate and measured data. Achieve continual improvement through small increment changes. So basically, if we would like to have some change, or if you would like to have some improvement in the quality, so we have to take a small steps, and then we can achieve the goal. Infrastructure enhances the systematic implementation of the improved activities. Suppose, as I have discussed, like if we have a good health team member, if we have health team, and if we don't have a good infrastructure, so we are not able to give the quality care to the person. So systematic infrastructure is also important for the quality care. Do not reinvent the wheel, steal shamelessly, and share senselessly. So these things we have to keep in mind when we're giving a quality care. Now, PhilHealth quality assurance framework, we have given, implementation of framework. 3 components are there in this framework. This is accreditation, clinical practice guidelines, and performance measurement. Accreditation program. We all know about the accreditation program. It is a skill survey, conduct 2 levels of assessment. First, they evaluate the compliance with documentary requirements. Second, they visit the provider site and evaluate the actual operation. So it is accreditation. It is mainly done by any organization who are having an expertise for that. So they are coming for the inspection. So first they are evaluating the documentation, then they are observing the site where a health team member they're providing the care. Accreditation program verifies the qualifications, capabilities of the health team provider to deliver the desired and expected quality of healthcare and services. Donabedian ideas describe the relationship between the structure, process, and outcome, and posit that an organization which right structure and process and place where provide a better care. So Donabedian, he has given the emphasis on, like, we should have good resource, human resource, we should have material, but at the same time we should have a good structure so we can give a good quality care. An important component of the accreditation process is determination of compliance with set standard. Accreditation standards shall be redeveloped in consultation with the healthcare industry, should be equally applicable to all the healthcare organization, regardless of whether they are hospital, day surgery, community services, some other type of health organizations are there. So if you're giving a care, so it should be applicable to the all area of the organization. Should reflect complementary best practice principle and achieve easily understand measurable. So these about the accreditation. Then we have clinical practice guidelines and clinical pathways. Ever increasing evidence point to the role of clinical practice guidelines and clinical pathways in the reduction of the variation in practice and consequently its outcome. These guidelines should be eventually through education, implementation strategies to adopt it as operational pathways in healthcare service providers. So these are the clinical pathways are there by which we are able to make it out how the patient getting a clinical care and their standard, their criteria, we can make it out. Then third point is performance measurement. Monitoring is an important component in the evaluation of an organization. Performance is allows measurement and assessment of patient care, other services process provided by the healthcare provider and organization. Performance targets shall be established the frequency with these targets and met. So shall provide the qualitative evidence, quality of the service. So evaluation or measurement is very important whenever we're giving a care to the by the patient or any organization. So evaluation or measurement is very important, so we can make it out whatever standard we have maintained, whatever we have planned for the care that we have given to the patient or not. Now there's a difference between the quality assurance and quality improvement. When we just talk about the quality improvement and quality assurance, there are some differences there. Motivation, measuring compliance with standard, continuing involving process to meet standard. So when we just doing a motivation or we are taking a point motivation, then in quality assurance we have to see the standard, compare with the standard, and in quality improvement it is a continuous improving process. Then means inspection, prevention. So in quality assurance it will be inspection, or in quality improvement it will be prevention. Attitude required defensive, chosen proactive. Then focus, bad apple individual or system process. Then scope, medical provider or patient care. And responsibility, few people are involved in the responsibility, and here not only the team member and patient is also they are responsible for the health quality care. Now 2005 core competency standard for the nursing practice in India, they have given the significance of core competency standards. So these standards are unifying framework for nursing practice, education, regulation, guide in the nursing curriculum development, framework in developing test syllabus for the nursing profession, tool for the nurses performance evaluation, basis for the advanced nursing practice, specialization, public protection from the incompetent practitioner. So these are the significant core competency standards are there. Now another 11 key areas are there which we can make it out for the quality nursing care. So these are 11 key points are there. First, safe and quality of nursing care, measurement, management of resource and environment, health education, legal responsibility, ethico-moral responsibility, personal and professional development, quality improvement, research, record management, communication and collaboration, teamwork. So these key areas are there. On the base of that, we have to see that by assessing this, we can make it out. We are giving a quality care by the organization or an institution. Now, PHILHEALTH, we have given the 7 component for the healthcare provider organization. These components first for the patient quality care, patient rights and organization ethics. So we have to maintain the standard. We have to respect all the patients, their rights and responsibility, opportunity for the patient involvement in care. So they should give the chance to plan their care. They can be involved in the patient care, confidential in security of the patient's information communication. So whenever we are doing care, we have to make sure that confidentially has to maintain, and security of the patient information has to be we have to keep. Feedback of the patients, staff code of ethics, resolution of the ethical issues. So first, patient right and organization, this is given by the PHILHEALTH 7 quality standard for health provider organization. Now second point, patient care. When we're giving a patient care, we have to maintain access standard, information about the service we are going to provide, entry standard. So when patient get admitted into hospital, we have to attempt the patient, and triaging has to be done, unique patient identification, informed consent, planning for the discharge and continue care. Assessment standard, when patients admitting the hospital, we have to take to the physical, psychological, social assessment, coordinating with the professional, regular assessment, proper documentation of the data, appropriate diagnosis, special need and assessment. Care planning standards, relevant to the patient need, evidence-based care we can give to the patient, clear and accessible information can be given to the patient. Third, leadership and management. In leadership and management, we have to make sure that leadership, effective working relationship between the healthcare member. They should be committee meeting regularly, manage performance assessment policies and procedure for operation. So these, leadership and management is also very important, giving a quality care. The human resource management. In human resource planning standard, HR need assessment, workload monitoring. The people, they should not have very heavy workload. Otherwise, it will going to be affect the quality care. Staff recruitment, selection, appointment, responsibility standard. It is also depend. These things are also based on the quality care. If the staff recruitment, they are appointed responsible persons, so they are going to give a quality care. So this procedure, job description, staff accountability, service provision by appropriate staff training and development is very important. So in between if the health team member, they're working in a hospital, so their training is very important and their development standard has to be maintained. Then information management, data collection, aggregation and use standards, timely and efficient data collection has to be maintained, standardized information, detailed medical charts should be there in the hospital, coding and indexing of data, records management should be maintained, and these records should be accessible at the time of need. Then safe practice environment, as I have discussed, safety is the first point in quality improvement. So patient and staff standard plan for the safe and effective care. Then maintenance of the environment standard. Then there should be emergency light, power supply, water supply, regular maintenance of the facilities. Infection control standards are there. So patients should not get the nosocomial infection from the hospital. Equipments and supplies standard. Whatever equipments and supplies are there, it should be regular and they should not have any problem. So even they can have some injuries or hazard to the patient. Energy and waste management standards has to be, we have to follow. Now, improving performance. How can we improve the performance? These are, we have to maintain the organized wide approach, collaboration with the new process care, managing responsibility, service unit and staff responsibility, evaluating of the care, and better services. Then confidentially with the data. So these 7 points are there. On the base of that, we can evaluate, we are giving a quality care to the person. Now we'll be discussing about the quality improvement process. In quality improvement process, we have 2 aspects are there in which we can give the quality improvement. First, we should have a quality circle and then we have quality team. Now, quality circle and quality assessment. So these they are help in provide the quality improvement process. Now, what is quality circle? It is mentioned by the Japanese quality expert Koro Ishikawa. It is a small group with maximum of 10 members who belong to this teamwork section. They meet the voluntary at least twice a month and elect their leader. Among their activities are identification of the quality related problems, understanding of their cause, formulation and implementation of the corrective action. So when we have to do the quality improvement process, so we can use this method. First, we can make a quality circle, then we can make a quality team. In quality circle, we should have 10 members or members. So we can assign their jobs and responsibility. We can find out what is the cause or what is the reason for the problem, and we can plan an implementation for the corrective action. By promoting involvement of the workers in a particular section, quality circle enhance personal self-image status. In the manufacturing industry experience, quality care has been highly useful in eliminating the low incidence defect and making process error proof. So quality circle is very important in finding out the problem, what all problem we are facing in the healthcare sector and how can we resolve that problem. Then United States tried to implement its own version of quality circle. So they have given the name zero defect movement. So because instead of quality team, they have given another word that is called zero defect movement. In 1960, it was adopted by the Pentagon for its contractor, but the movement did not catch on. Part on the problem, zero defect movement, according to the critic, it is focused on the output, not on the process. So basically that process was not work out because they have given the emphasis on the output. They have not given the emphasis on the process. So process is also very important for the quality care. Now, what is quality circle? Quality circle is a group of people, 5 to 10 workers, frontline workers, one work area of hospital meet regularly to identify the solve problem and their work area using their own resources. So basically, these are the quality circle. Doctors, nurses, other paramedical personnel, support staff can be belong to one quality circle. The quality circle approach to problem solving database and participatory action-oriented problem are identified after systematic collecting information from the workplace. So these group of people, they can meet together, they can find out what all problem they are facing in the area. Quality circle member are directly involved in all the steps. So basically, they are directly involved in the patient care. They are doctors, they are nurses, they are paramedical person involved in the quality circle. Solutions are feasible, practicable, and doable within several months and may be incorporated to hospital-wide routine or policies. Now, what is quality team? Quality team is a quality circle with a bigger scope. At least two aspects are there. In quality team, we have manager as well as the frontline worker. It involves more than one area process of the work and often tackle the cross-functioning issues. The first step in the initiating the quality circle or team, the selection of the quality leader. So when we're making a quality circle or quality team, we have to first elect a person which is quality circle leader responsible for the facilitating, promoting quality circle activities in the healthcare. This person should have training on the basic quality assurance, statistical process control, and other quality circle tools. Quality control leader are supposed to recruit member into the quality circle. Quality team promote consists of the jobs and responsibility of the quality team. They are planning, implementing company-wide education programs, overseeing or coordinating with activities of quality circle, holding quality circle conferences, establishing a award-giving system to top-performing circles, ensuring a mechanism for the adoption of quality circle recommendation on the company. Quality circles and teams evaluate performance through self-evaluation and management evaluation. So basically, when we are doing our evaluation, so two kind of evaluations are there. So they can do self-evaluation and management evaluation. So this is evaluation of the quality circle, quality team. Now, self-evaluation can be achievement of the set targets. So when they have make a team, so they can make it out whatever they have set the target, they are able to get it or not. Meeting schedule, attendance in the quality circle activities, extent of involvement in quality circle work, familiarity with the utilization and quality tool. Then management evaluation can be meeting annual target. So basically they are long-term evaluation, and self-evaluation is a short-term evaluation. They're demonstrating the effectiveness of quality circle activities, corporate among members, management satisfaction with the outcome of quality circle activities. So basically two evaluations are there. First is self-evaluation and second is the management evaluation. So now how they approach the problem. So quality team and quality circle, they first select a theme, understand the current situation and problem, create a plan for the action, analyze the root cause, develop and implement the countermeasure, confirm effective to countermeasure, and standardize and institutionalize the countermeasure. So basically these team and circle, they are select a theme, they select a problem, then they understand the current situation and what are the causes for the problem, and create a plan for the action, analyze the root cause, what can be the reason why they're having this problem in their particular area. Then they can develop and implement countermeasure, confirm effectiveness or countermeasures, standardize and institution countermeasures, or they can make it out. So this is all about the quality, how can we do. Now next we have audits are there. We have audits. By audit we can make it out how the quality care is given to the patient. So these four kind of audits are there. These medical audit, they are nursing audit, clinical audit, risk management, and peer review. So nursing audit, by providing a care, these audit can be performed by the nursing personnel. Clinical audit, the clinical area, the care we are giving to the clinical area. Risk management, so we have to provide a safe care to the person, so we can make it out what all areas are there where the patient can have risk. And peer review evaluation can also be done for the medical audits. So this is all about the quality care and how can we use the process to improve the quality. So now I'll be going to deal with the quality improvement tool. I just going to deal with one tool only, and the rest of the tool will be dealt by SHERIN ma'am. So first tool I'll be going to discuss, that is PDSA tool. So quality improvement project and studies aim to making a positive change, effective, favorable outcome. So whenever we are giving quality care, we need to have certain tools are there. On the base of this tool, we can make it out we're giving a quality care or not. This method has been widely used by the Institution for Healthcare Improvement in Rapid Cycle Involvement. One of the unique feature of the model is cyclical nature. impacting assessing change most effectively accomplish small and frequent PDSA rather than big. So in PDSA, what happened, we have to find out the problem that we have discussed by the, what we are doing in the audit. So we have to plan, we have to do, we have to study, and we have to act. So these, suppose we have any problem in the particular area, so we can make it out what can be the plan for that, how can we resolve that problem, what activity we can use for that, what implementation can be done. Then we have to study that what this implementation we have used, whether it is effective or not, and act if it is useful, or it is applicable to the situation, and if this implementation solve the problem, so we can use that implementation. The purpose of PDSA, quality improvement effort, to establish a functional causal relationship between changes and specific behavior. Then it has two cycles are there. What is goal of the project, and how will be known whether the goal is reached, and what will be done in the reach. So in PDSA cycle, we have 4 components are there. First, we have to plan, then we have to do, then we have to study, and then we have to act. So this is the PDSA cycle in which we have to plan. So we have to find out what is the problem in our area, objective, questions, and predictions, plan to carry out the cycle, who will going to do the plan, what kind of plan we can do, where we can plan the situations, do carry out the plan. We have to form, first there is a planning. So if we have any problem in the health care system, or in quality process, we are not able to give the quality care, so we can plan how can we resolve the problem. Then we have to carry out the procedure, what all documentation problems are there, we can do implementation, and these implementations should be applicable, they should be acceptable to the person, or for the health team member as well as for the patient. Then we have to study. After implementing the that implementation, we have to do the analysis. We have to do the analysis, and after doing the analysis, we can make it out whether we are able to accept that implementation, or we need to have some changes, so that we can done. And after that, we have a last point, that is called act. What change are to be made? So this is called next cycle. So this is about the PDSA. Now, model for the improvement, what we are trying to accomplish, what we know that change is an improvement, what change we can make. So this is about the PDSA cycle. So this is a tool by which we can make it out where we have a problem in the healthcare system, and how can we, resolve that problem. So these PDSA is a focus methodology. It is a focus methodology in which we are finding out the process improvement. We organize a team that knows the process, clarify the current knowledge and process, understand the variability and the capability of the process, select a plan for the continuous improvement. So first we have plan. The first plan they select to set up a heart failure patient over 65 with connected health programs upon discharge. Do the team implement these one change during the fixed time period? Check the team measure the checks and result their connected health discharge intervention. So like they have taken a plan on patient with heart failure. So they have decided that by giving a discharge education, so they can have some problem, they can resolve the problem. Then they have to study or check the team measure, then act. The team act on the result. If the intervention work, then the team keep the new program in their discharge process. They may even take some action to try to further improve. And 30-day readmission, they would try to another idea and run it the PDSA plan, do study, act. Basically it's a small cycle. So first we have to do plan what the problem we have, what implementation we can do, then we have to study, and then we have to suppose if our intervention is not worked, or so we can plan another intervention for that. So this is all about my topic. Thank you so much for your patient listening. So if you have any query, any doubt, so you can write in the chat box.
Yes, ma'am.
So if anybody have doubt or query, so they can write in the chat box.
Yes, ma'am. Yes, ma'am.
Okay. Thank you so much, ma'am.
Thank you so much, ma'am, for the wonderful presentation and sharing the beautiful knowledge with us, ma'am.
Thank you so much, ma'am.
Yes, ma'am. Any queries regarding any questions regarding the presentation, please write in the chat box. Okay. Thank you so much, ma'am. I would like to welcome our next speaker, Dr. SHERIN Sarah KOSHY, ma'am, Professor, Department of Obstetrics and Gynecology, KIMS College of Nursing. Please, ma'am, to take over the session. Ji, uncle.
Thank you, Sushmita madam, MIKKI madam. Am I audible?
Yes, ma'am, you're audible.
Good evening, all. It's my great pleasure to be with you all in the evening. From the previous session by MIKKI madam, I think all of you got a clear idea regarding the aspects of quality, isn't it? Shall I share my screen?
Yes, ma'am, please share your screen.
Quality improvement in healthcare system.
Yes, ma'am.
So, quality regarding the main aspects and the introduction, everything ma'am given an introduction. Then also, I am just introducing my topic. Quality is not an act, it is a habit. The American National Standards Institute and American Society for Quality defines quality as a totality of features and characteristics of a care or service that bears on its ability to satisfy given needs. Quality healthcare is the responsibility of everyone. Everyone includes planners and educators, payers, researchers, healthcare professionals, patients, and their families. When everyone works together, better professional development, better system performance, and better patient and population outcomes are achieved. See the image. What's reflecting? Offhand, I would say you are suffering from an arrow through your head. But just to play it safe, I'm ordering a bunch of tests. So in most of our hospitals, they may have simply ordered some tests for the patients without assessing the patient properly, isn't it? The focus for quality in healthcare is on simple preventive maintenance rather than total service maintenance. When healthcare leaders analyze patient data to come up with a plan to reduce post-operative infection or uses data-driven approaches to shorten the average length of hospital stays, those are the examples of quality improvement initiatives. Remaining improvement methods means what are the real-world impacts of quality improvement? So which area needed improvement? So I am listing reduction in medication-related adverse events, optimization of sepsis care, decreased number of urinary catheter infections, reduced hospital readmissions, decreased medication administration errors, improved electronic medical record documentation, improved care coordination among departments. So these are the main areas needed quality improvement. Quality can be a common paradigm to address the need of all groups in healthcare and define quality improvement. So in an elaborative way, it is a systematic approach that is guided by data to improve the quality and safety of healthcare delivery by Dept.of. And in a simple way, we can define it as safe, timely, effective, efficient, equitable, and patient-centered care. And the processes that are inefficient and variable, changing case mix of patients, health insurance, differences in provider education and experience, and numerous other factors need improvement. So the tools can be utilized to continually improve the effectiveness of quality management system, and the IT, that is the integrated health management information system, and proper leadership can facilitate the implementation. So I'm moving my topic, quality improvement or QI methodology. So these are the 8 aspects I am going to deal. Model for improvement, PDSA model, I think Madam already discussed. So from the second one, quality improvement framework, quality improvement methodology or TQM, lean, Six Sigma, trigger tools, root cause analysis, and joint commission with national patient safety goals. So, quality improvement framework. So, it is developed to influence and guide thinking, planning, and healthcare delivery. So, it stresses on quality, safety, and improvement in patient experience. So, quality improvement framework is developed for what? It stresses on the quality, safety, and the improvement. And finally, it's aimed to strengthen the quality and ultimately provide a safe, effective, and person-centered care across all services. So, for that framework, we have some drivers. That means the number of drivers that work together to improve the quality. So, we can discuss each one. Leadership. So, leadership is responsible for shaping the culture, creating conditions, and modeling the behavior necessary for quality. So, we need the quality. So, it's necessary. We have the leadership. So, who will lead us? Board members, senior leaders, managers, and the clinical leaders must utilize every opportunity, show their commitment to building quality by actively demonstrating the values and paying attention to staff and patients and checking their providing care. Patient involvement, that's the second aspect. The central focus is the patient. So it guarantees meaningful partnership with the carers, patients and their families, and make sure that quality care is tailored to patients' preference and needs. And the staff engagement is another essential aspect. In the long run, teamwork, trust, open education, staff well-being, coaching and mentoring, staff feedback and respect also to be established. And standardization, that is, the sustaining quality improvement in healthcare requires promoting and supporting the use of an agreed set of improvement methods. So we have the leaders, and staff, patient, and we need some improvement technologies. And the measurement aspect, use measurement and information to highlight when improvements have occurred and when they have not, as well as areas where improvement is needed. So we need to measure accurately for further improvement. And last one is leadership support. The board members and the executive management together with the staff, and they should have the proper skill, necessary skill and knowledge to measure and drive quality care. And third aspect, quality improvement methodology. Okay, so here also we have some methodology or approaches. Number one is system thinking. So consider the physical environment. So for providing quality care, we need a systematic or qualities for actual physical environment and system for practicing to reduce the error and promote patient safety as well as best practice. So psychology of change. This method maintains that leaders who practice quality improvement should create a shared vision of the future of the organization with their staff. The staff also should have a common goal and it can contribute reasonably to the vision. Theory of knowledge. It maintains that any change in the theories or process should be tested through PDSA or PSDA, that is Plan to Study Act. So that's a main model for quality improvement. Theory of constraint is generated from the idea that a chain is only as strong as its weakest link. We know we have some positives and negatives. So strong chain and weakest chain also will be there. So we can connect it. This method involves identifying the weak link and recognizing the impact of mismatch between the variations. So where we have the variation or deviation, that we can connect with the proper methodology. And there is an important term coming under this quality improvement methodology, that is TQM. I think MIKKI ma'am already discussed, then I go a little bit fast I will do. Total quality management, otherwise continuous quality improvement, that is CQM. So W. Edward Deming, the father of concept of TQM, has defined quality as a strategy aimed at the need of the customer. This strategic definition has received widest international acceptance. So the principles including customer focus, obsession with the quality, scientific approach, teamwork, long-term commitment, continual improvement system, education and training, freedom through control and unity. It addresses not only the direct medical services of diagnosis and treatment, but indirect operations. That means not only the medical services directed to the care of the patient, in addition to that, regarding the purchasing, auditing, complete administration also, we are assessing in the TQM. And the nurses are the main personnel that contribute to this implementation. And here you can see the essential components. I'm just noting the main points. So in total quality management, the main components including continuous improvement, quality improvement, accurate evaluation, involve all the staff, employees, and we are focusing on the patient, consumer. And here, this is the process. So we have two divisions. So the number one, that is from the organization, directly one arrow is going to the production process. Okay. So there we are doing one quality check, and it may move to the proper improved products, and directly customer satisfaction may occur. And if we are planning, or if we are analyzing, and if we are maintaining proper relationship with the staff, and we are gathering them means, that is the lower one. That is, in an organization, total employee participation, that means the workforce with the management. It may lead to, we are following some analytical methods, and we are doing some performance analysis. Then the production process will be more quality, and it may again good customer satisfaction will gain. And these are key points, key elements. Total quality management, including guaranteed customer retention, enhanced productivity, feedback at every level, boost employee morale, error prevention, improved brand image, and employee commitment. These are the other aspects. And the total quality management have some principles, that is customer focus, employee involvement, integrated system, process-centric approach, systematic flow, continual efforts, factual decision making, relationship management. So I'm just going through the customer focus means we need to prefer the customer, what he want or she want, for what purpose they are coming, for the minimum requirements we need to satisfy. And employee involvement. Here also we need to create an employee involvement, and we can provide proper orientation, and we can involve all activities. Then integrated system, that means then standards, some ISO 9000 standards and all. We provide some quality products, at that we can connect with the institution. Then process-centric approach. Process-centric approach, that means that after passing different process, we are producing one product. So that should be in a systematic flow. Then systematic flow means considering a systematic flow for producing each stage. Through different stage only, we are producing the products. Then continual efforts. Continual efforts means people at every level need to be alert in the regular quality checking. Then factual decision making. Here also the organizational performance using a specific data regarding sales, profit, everything. Then finally the relationship management means regarding all stakeholders like customers, employees, we can maintain a relation. And the tools under TQM. Control chart, scatter diagram, histogram, flow chart, fishbone diagram, check sheet. Number one is control chart. It is a graph used to study how a process changes over time. Always as a central line for the average, an upper line for the upper control limit, and a lower line for the lower control limit. So this is a control chart. Here you can see this is the middle, there is an average line, and upper control limit and lower control limit. So while this control chart shows a process over a specific period of time and identify trend, shift, and pattern. So this is the one model, one tool we are using for total quality management. So with this, we can come to know what changes may occur over the time. Then scatter diagram, I think you all have in statistics and all, it's a graph that shows the relationship between two variables. So here the hours of training and the difference. So if the health professional have she or he receive proper training means it should reflect in their care. Then third is histogram, accurate representation of the distribution of numerical data. It is an estimate of the probability distribution, the continuous variable. Histogram also, so it's another tool. And Pareto chart, Pareto principle, that is 80/20 rule, states that for many events, roughly 8% of the effects come from 20% of the causes. Okay, so due to 20% of the causes, most of the side effects or errors may come. So combination of a bar graph and a line graph. So Pareto chart is the combination of a bar graph and a line graph. Each bar represents a type of defect. So here you can see the combination of a bar diagram and a line graph. Okay, and each bar usually represents a type of defect, and the height of the bar represents the unit of measure. And use of Pareto during any Six Sigma project that we will deal in later. The intention of the project lead is to identify and work on those minimum causes which can maximally impact the project goal. Okay, so in Six Sigma project also we are using the different charts, tools and all. So the Pareto chart mostly using in the Six Sigma project, and here we can identify the 20% causes that leads to the 80% side effects. And next is flow chart. It's a type of diagram we are using for representing the workflow. This is an example for flow chart. And another main aspect is fishbone diagram or Ishikawa diagram or herringbone diagram or cause and effect diagram, and other name that is Ishikawa. Okay, so this is the cause and effect diagram, and there you can see it's like a fishbone. Okay, so quality problems may occur due to the aspect suppliers, workers, machines, temperature, process, and material. So any defect or delay, any errors in these aspects, it may lead to quality problem. So little more in depth we can see here. So measurement of faulty testing equipment or incorrect specification, improper methods, and inside of human aspect, poor supervision, lack of concentration, inadequate training, in machine case, tooling problem or old machines, then environment, inaccurate temperature, then materials, any handling issues or defective from vendor side, process, ineffective quality management. See, this all together may lead to quality problem. Okay, so fishbone diagram and cause and effect diagram we will deal later in one more aspect. Then check sheet or checklist. All of you know, simple data check-off sheet designed to identify type of quality problems at each workstation, per shift, per machine, per operator. So we can maintain a checklist or check sheet for each department. So here you can see the defect types, which are area or which are items, materials have the defect and the number of defects, and the number also we can maintain in form of a checklist. Okay, so that's regarding the quality methodology tools, second aspect, and we can just see what are the quality improvement examples. So number one is reducing unnecessary cesarean sections. Okay, we know the CS rates have been increasing nowadays. In 1995, 7,85,000 out of 4 crore women gave birth through CS. This was a high rate, 20% rate. Even in today's high global CS rate, this rate was relatively high. The Greater Cleveland Health Quality Choice Coalition produces a biannual health report that documents the outcome of the patient in 27 local hospitals. And with their report, as a measure of performance in these hospitals, they tackled the number of CS deliveries. And several Cleveland hospitals implemented and developed guidelines that fostered collaborative efforts to improve care, leading to a fall in the aggregate trend of total CS rates. That means they done a quality improvement method, and then they finally taken some measures to reduce the CS rates. And second, preventing drug reactions. So they're responsible for significant mortality, adverse drug reactions. So as a response to this problem, LDS Hospital in Salt Lake City took steps to improve its rate of adverse drug occurrences, included providing timely feedback to physicians, tracking patient drug allergies in a more effective way, monitoring kidney functions while administering antibiotics with toxic effects to patients, as well as managing antibiotic through computerized disease management program. Okay, and with the effort, their result may come, that is decline in the adverse drug reaction caused by antibiotics by 75%. And this was an astonishing achievement that is among the best quality improvement examples today. Okay, and our fourth methodology is lean. It's one of the another technique we are using in the quality improvement method. Lean is the act of reducing waste and adding customer-defined value to products and services. So we can reduce the waste. Lean means doing more with less while doing it better. Okay, we can reduce little, but we can gain more. In order to assure long-term survival in today's economy, organizations must continually reduce waste. So, discussing 8 types of waste. Okay, so in lean, we can focus on 8 types of waste. Number 1 is motion, unnecessary motion of personnel, equipment or information due to inadequate workspace layout, missing parts or tools. So, unnecessary motion. And second is transportation. Transporting items or information that is not required to perform the process from one location. It is unnecessary. Okay. Then waiting, time waiting for parts, tools, supplies, or previous process step without any significance. Then overproduction, producing more product than what is required to meet current demand. Fifth, defect, non-conforming products or services requiring resources. Means no use or not required products why we are producing. That is defect. Then inventory or information that is being stored or not being processed likely due to line imbalance or overproduction. Okay, there is overproduction of non-conforming products. Then seventh one, unrecognized talent, failure to effectively engage employees in the process and fully utilize their knowledge and skills. Okay, so effectively we can engage those who are talented or those who are having the knowledge, we can use them. Then extra processing, activity that is not adding value or required to produce a functioning product or service. So extra producting, so same activity, same aspect, activity that is not adding value. These are the 8 waste we need to reduce using lean. So how to implement lean? Number 1, commitment to succeed. So briefly, I can share the point. An organization cannot expect to implement lean overnight. Means simply we could not force, providing stress to the employees for please reduce waste, please reduce waste. It will require time, resources, and hard work to build a robust and effective lean program. What is robust? Robust means it should be strong and healthy. Then employee training, proper training in lean methodology and all the tools along with the regular guidance and encouragement will greatly improve team's chance of success. So employee training to be provided and identifying the waste. So one method used to discover the waste is value stream map. So for easily identifying the waste, we have some mapping process. So it depicts how materials, parts, and process flow through the organization onto the customer. Okay, so which waste is producing by the organization and how it's passing to the customer. In addition, the BOM should identify how different actions and departments are interconnected. Okay, miscommunication, how they are interconnected, that also we can identify. And through the examination, the team can identify which action are the waste. The team can then develop a future state map. So in future, if the waste aspect are increasing or is accumulating, what may happen in the future state, that also this value stream map can assess. So look for ways to change to a pull system where production is based on customer demand and eliminate the waste. For this, determining root cause, RCA, that is root cause analysis. In detail, I will deal later. For just in lean therapy, I'm just pointing this root cause analysis. Here, brainstorming and use of fishbone or cause and effect diagram. So determining root cause means the main cause we need to identify with the help of brainstorming process, and fishbone, we already discussed fishbone diagram or cause and effect diagram. Taking action. So we identified the waste and we need to remove. So once the root causes for each phase have been determined, the action should take into account any effect on the rest of the process. If the waste is prominently means if it is increasing, what may come next, what effect may come. So anytime we make a change, new content is introduced into the process, and it is known as FMEA, that is failure mode and effect analysis. And this also I will deal in detail later. Okay, so the taking action means we are doing failure mode effect analysis. And sixth is tools for reducing waste. We have some tools for reducing waste that is known as 5S. It is implemented properly and with an organized work area, we can reduce the 5S. And you can see what are the 5S. SARA or sort means separating the essential from the non-essential item. Straighten or straighten, organizing the essential materials, everything has its place. Say so or shine, cleaning the work area. Sex to or standardize, establishing a system to maintain and make fibers a habit. Shitsku or sustain, establishing a safe and sanitary work environment. These are the 5S. And why this term may come, that is, it is a methodological way to organize workplace. Okay, it is a overall philosophy of working. And 5 phases we have, and the term, this Japanese term beginning with the letter S, that is Seri, Satan, Seiso, Sextu, and Shitsuku. Hence, the name is known as 5S. And recently, and a 6S came to develop that is safety. Some companies are following 6S, that is safety. And the seventh methodology in lean is JIT, that is just-in-time manufacturing. This is a strategy for eliminating the deadly waste of overproduction by delivering a product or service just in time. That is just-in-time manufacturing. What is just-in-time? That is deliver just the right quantity at just the right time. No more, no less. That is JIT. And next is Kanban. Kanban is a Japanese term for visual signal or a card. So it is a card. And to signal the need for replenishment of component parts or supplies. What is replenishment? That means if something excess, they will not give the products. Okay. When an operator or material handler pulls a set quantity of parts, the corresponding Kanban card to be returned to the work cell area. Okay. Then only they will get the next set of equipments. The quantity of parts listed on the card is indicated by a color code tag, and that amount is produced. Here you can see different columns. You can see black log, then to do, then process, like this. So we have some of equipments they already intended for the specific nurse that is in the black log. And which are the items now she is using and which are going to be repaired, and what's the next means in that process or system or specific care of patients, this much equipment she used. So what's the next one? Then with that color code, they can identify. Okay, that is Kanban card. Like this, they can maintain which all processes on progress and how much need to do, like that. So this Kanban card also, we can improve the quality. Then ninth one is mistake proofing or poka-yoke or fail-safing. Mistake proofing, that is reducing or eliminating errors in a process, can be achieved by either adding more detection control like this additional inspection, special tool, expensive test equipment, or through the implementation of preventive control. That means mistake we can identify by some extra inspection or some special tools. And here the goal to simplify the step by making the correct action simpler to perform than the error. Eliminating the step by asking, is this step required? Error proofing the step, making it impossible to create error. Means how we can prevent error. If error occurred, how we can correct it. That is mistake proofing. And next is SMED, that is single minute exchange of die. That's our 10th point coming under lean. SMED greatly reduces the amount of machine downtime for tool changes. That is, the equipment changeovers consist of two types of operations. That means regarding the machine. Internal elements means steps performed when equipment is not running. Equipment is not running, then also error may come and the system is working. External elements means steps performed when equipment is running. So this both type of operation or elements we need to check, we need to assess in SMED. By implementing a robust SMED, we can realize improved efficiency through increased machine uptime, permit the running of smaller load size, improve responsiveness to demand, lower inventory level, and all we can assess. And the 11th is Kaizen. It is a key building block for a robust, sustainable lean initiative. Okay. Kaizen technique means to improve productivity, reduce waste, eliminate unnecessary hard work, and humanize the workplace. When everyone is working to reduce waste and improve processes, the organization becomes lean. So in lean methodology, the main important is Kaizen. Kaizen means through proper planning and education and application of lean tool, processes can be optimized and based. That means integration, all the steps and the workers, mean the staff together, they need to involved in the process. That is Kaizen. When the workers are involved in the improvement, they tend to feel more ownership of their processes. Okay, so these are the 11 aspects coming under lean. And just we can say it's a project for improving ED patient flow. ED means emergency department patient flow. It means the project aim is reduce ED loss. That means emergency department length of stay. 50% reduction, how we can reduce it. That was the one of the project. And here process improvement is we need to reduce waste. So for that, work standards and evidence-based clinical practice, batching of orders eliminated. That means as per the need or the physician's order. Systematic way only the SPO or the orders to be performed. Right supplies and equipment in the right place, eliminated unnecessary S&D, that means supplies and equipment, admission process streamlined. So with that, they reduce the LOS. And what are the other waste in the medicine? We are discussing reducing the waste in lean. So what are the other waste? Surgical infection, preventable adverse drug events, ventilator-assisted pneumonia, equipment failure, etc. And some examples, I will just read one example, that is redesigned patient rooms. That's another lean healthcare example. That means the supplies, medication, and electronic record keeping systems were relocated into patient room, which allowed the nurses to spend 70% more of their time with patients. Additionally, patient safety was improved by equipping rooms with ceiling lift, beds with alarms and scales and other equipment. Like this, we can redesign the patient room. For what? Spending the nurses more time, 70% with the patient. That is one of the lean healthcare example. And one more, that is patient safety alert system, PSA. Here, all staff are to report possible patient safety issues. The reported concerns are quickly investigated and the interventions are promptly implemented. That is in that initiative in Virginia Mason. Because of that system, the liability claims at Virginia Mason decreased by 74% from 2005 to 2015. And next, fifth quality improvement methodology is Six Sigma. PDSA has changed over the years and has become DMAICS, that is define, measure, analyze, improve, and control for Six Sigma. So PDSA you already got. This PDSA changed to DMAICS for Six Sigma. It improved the quality of output by identifying and removing the cause of errors and redirecting these resources for quality and efficiency. So here you can see how the name Six Sigma occurred. So you know this probability curve. The word is a statistical term that measures how far a given process deviates from the perfection. So from the perfection, how many are deviated, means how much defects we can identify. The central idea behind Six Sigma is that if you can measure how many defects you have in a process, you can systematically figure out how to eliminate them and get as close to zero defects as possible. So that's our aim, isn't it? In quality improvement, we have to aim zero defects, no issues to be there. Okay, so zero defect to be there. To achieve Six Sigma quality, a process must produce no more than 3.4 defects per million opportunity. That is DPMO. 3.4 defects per million opportunity is a gross confusion of the following situation. And a little bit clear, here you can see Six Sigma, the percent defective is 0.00034%. So you can see the upper limit and the lower limit. So this is the main aspect. Six Sigma refers to the tiny area under that bell curve where the probability of producing a defect is almost nil. There is no defects while providing that care. So Six Sigma is the most effective way to providing quality improvement. So to improve quality of products and service, customer satisfaction as well as profitability. And the defects may range from long waiting. Here also we know what are the defects or poor quality may range. Long waiting time to wrong diagnosis, prescriptions and treatments. Thus, the employee Six Sigma will help improve quality patient care, reduce waste, and eliminate these defects. Okay. And it plays an important role in making information easily accessible to patient. It also ensures the voice of the patient is central to consideration in healthcare. So the patient-centered care we can provide. And briefly, the objectives, that is overall business improvement, remedy defect, reduce cost, reduce cycle time, increase customer satisfaction. Okay, and another important aspect is belt hierarchy in Six Sigma. Okay, so here you can see in this triad, a yellow belt, green belt, black belt, master black belt, and the champion. So who all are they? So the yellow belt, that is people with basic knowledge about quality, and green belt who have gone under requisite training for improvement of project with support from the black belt. Black belt who have undergone black belt training and who have detailed understanding of Six Sigma concepts. Master black belt work at least 10 to 15 high impact black belt projects, and they become eligible to become MBB, that is Master Black. then the champions are the people who consider quality above everything else. Okay. So these are some positions they will give if you are certified with the Six Sigma project. Then the DMAIC approach, that is define, measure, analyze, improve, and control. That is the main elements coming under Six Sigma project. And here you can see what are the aspects: define problems and objectives, measure what do we need to improve, analyze process and factors of influence, and improve the implemented aspect, and the control, assure that improvement will sustain. Okay, we need to assure the improvement is sustaining, it's maintaining. That is DMAIC. Okay, and I'm not dealing more. Define and measure, analyze, improve, then control. And Six Sigma in healthcare management have some tools. Okay, I'm just listing CAP, FMEA. Already we heard the term DFSS, QFD, cause and effect matrix, T-test, control chart, and DOE. So CAP, that is change acceleration process. Here it is designed to accelerate implementation and increase the success of organizational change. And here the employees and management usually refuse to accept change. We know if in the same way, if you are doing one process, it is okay. All are happy. But if any change means it is unpredictable, difficult, uncomfortable, and risky, isn't it? So to achieve CAP efficiently and effectively, following are some steps. So the leading change, that means the leader should be cautious of their messages and creating a shared need. Need for change must be outweighed by the resistance by the organization. That means why we need a change or the need, the reason to be discussed with the whole team. Shaping a vision, that means already we have a vision and we already discussed with the team members, and it is the direction towards how one is going to achieve the outcome of change initiative. Is a clear statement which tells what, why, who, and when the organization will address the changes. Okay, so when the generation is going for the changes for the establishment or the sustaining the institution, we need to change. Mobilizing commitment by business functions in the change to make it work and demand management support in order to support the changes, making the change last. That means once the change is started, the key is to sustain the change. Monitoring the process of the change initiative. That means providing focus, direction, and momentum throughout the change process and changing the overall system and structure. Here we need to reinforce the change. Then FMEA. Okay. Next is FMEA, that is failure mode and effects analysis to detect and prevent the errors before they occur. To identify and eliminate concerns in the early stage of process development or new service delivery. Okay. So with this table I'm sharing, that is FMEA, that is calculation of risk preference number. So there you can see failure mode A, B, C. Severity. Severity means A, one procedure or type of care. For that, the side effects may occur in severe level, and 5, the score is 5, and probability of occurrence. Okay, there is a chance to occur some side effect, that is 7, the score, and probability of detection. Okay, and we are detecting, we need to suspect some side effect, that is 4. And we can together we can multiply, means it will come to 140. Okay, and the B and the C also having, we can calculate, and the RPN, that is the risk preference number. Depend upon the risk preference number, we can assess the errors or the side effect what have occurred here. That is FMEA is the way to find out the defect. And DFSS, that is designed for Six Sigma. Here, the need of the customers and the competitors should be measured and determined. Like this, that is D, define, measure, analyze, design, optimize, and verify. Okay, this DFSS, we can elaborate it like this, that is define, measure, analyze, design, optimize, and verify. And QFD, that is quality function deployment. The QFD helps Six Sigma black belts drive. We already told the certification, Six Sigma certified person will get the position black belts, and with them the QFD can connect and they can provide customer focused development functions. It consists of set of procedures to identify, communicate, and prioritize customer requirements. okay, with the proper product planning, product design, process planning, and process control. With this, we can identify the voice of the customer. That is quality function deployment. And cause and effect matrix, C&D matrix helps for Six Sigma project. C&D also may support the Six Sigma projects, and the tool that helps Six Sigma teams select, prioritize, and analyze the data they collect over the course of a project to identify the problem with that process. And this is cause and effect matrix. And in the upper area, you can see the output variable, what the customer is facing. And down the lower part, you can see the input variable. Okay, so together the total value we can measure how much, means which are the area needed improvement we can identify. It's the cause and effect matrix. And t-test, we know it is a method to determine the statistical difference between two groups, not just a difference due to a random chance. So any comparative analysis of patient blood pressure before and after they receive the drug is likely to provide reliable result. That t-test also we can use. And control chart. Control chart we discussed previously, and in Six Sigma also we can use control chart to assess the process stability. And the three components we discussed: central line, upper and lower line. DOE, that is design of experiment. DOE also helps Six Sigma black belt, and statistical technique that encompasses the planning, design, data collection, analysis, and interpretation strategy used by Six Sigma professional. And the DOE, that is design of experiment, they are assessing the relation between the factors and the output. Six Sigma project example. Okay, now we completed the Six Sigma project, and it's an example. That is reduced obstetric waiting time. In Kuwaiti private hospital, Six Sigma was used in its obstetrics and gynecology clinic to reduce patient waiting time. For patients with appointments, waiting time was reduced by 63% on weekdays and 67% on Saturdays. For walk-in patients, the waiting time was reduced by 46% on weekdays and 55% on Saturdays. The hospital improved patient satisfaction and profitability by improving the process. The waiting time, they planned and they reduced. With that, they got the improvement in the hospital. Okay. And next, I'm moving to one side, that is Six Sigma project stimulator in healthcare. It is by Management and Strategy Institute. They are providing a certification course, that is Six Sigma project stimulator in healthcare, and we can enroll here. And there they will give some case studies they will give, and they are providing the course syllabus and sales brochure. And if you are completing this project, you will get the certificate like this. Okay, this is Six Sigma project stimulator in healthcare. Are you all there? Is it audible?
Yes, ma'am, it is audible.
Yes, okay, ma'am. Yes. At least 44,000 people and perhaps as many as 98,000 people die in hospitals each year as a result of medical errors that could have been prevented. With that, we are moving to the trigger tools. So that's an introduction. Cost-effective methodology and have been widely used both in hospitals and general practice to identify, quantify, and track patient harm in order to improve the quality and safety of services. So we are using the trigger tool. And the options are retrospective review of random sample of patient records. We know what is retrospective and prospective. Okay, so retrospective records and the prospective surveillance also we can do for improvement and prevent harm. And here you can see some trigger, these are the trigger tools. Here you can see C1, C2, C3 up to C15 and S1, S2, here M1 to M13, and here also L1, L2, L3, L4, and P1. Okay, I think it's little visible. Okay, so these are the some criteria, and we can just move to one situation. So this patient, the condition you can see there, and the positive triggers identified include S3, admission to the ICU post procedure. Okay, so ICU admission, and M10, that is antiemetic use, then M11, that over sedation and hypotension. These are the management in that hospital they provided. Okay, And by providing the care, we are planning to assess the adverse events. That's the purpose. So trigger tools we are using to assess the adverse events. So this is a scenario. Okay, in this scenario, the patient are providing care in the ICU and antiemetic use there and oversedation and hypotension. And in here you can see that is S3. Here you can see S3, that is admission to intensive care post-op. Okay, like this, these are the criteria. Okay. Here you can see the IHA Global Triage Tool. IHA Global Triage Tool. The categories, category A to D. Category A to D are coming under the IHA Global, and remaining E, category E, F, G, H, I, and all of the NCC MERP. NCC MERP means that is the National Patient, means National Coordinating Council for Medication Error Reporting Prevention. They have prescribed this EFGHI. From the NCC also, they added the categories in the IHA Global trigger tools. Okay, so category A, that is circumstances or events that have the capacity to cause error. B, an error that didn't reach the patient. Category C, an error that reached the patient but didn't go harm. Then category D, an error that reached the patient and required monitoring or intervention to confirm that resulted in no harm to the patient. Category E, temporary harm to the patient. Category F, temporary harm to the patient and required initial or prolonged hospitalization. Category G, permanent patient harm. H, intervention required to sustain life, and I is patient death. Okay, so here you can see the S3, admission to the ICU post-op care, post-procedure care, in which category. Here written the adverse events identified were re-intubation and significant nausea. So by providing care, the patient were undergone re-intubation and significant nausea were noted, and the re-intubation was classified as category H and the nausea as category E. Here you can see category H is the intervention required to sustain life, and the another one is category E. Category E is coming under temporary harm to the patient and required intervention. So like this, with this IHA Global Trigger Tool, we can identify the adverse events. Okay, so IHA Global Trigger Tools. And this is the last part of the trigger tool. Here, the adverse events per 1,000 patient days we can calculate here. Total number of adverse events or total length of stay for all records reviewed multiplied by 1,000, and we can, the events we can identify, and with this we can reduce by proper interventions. And the 8th is root cause analysis. Root cause analysis we already deal in brief, revolves around the process of identifying the source of a problem and looking for a solution in a way that the problem is treated at the root level. So here you can see it is a popular tool that can determine the basic underlying cause of a problem through a series of specific steps. So the steps is listed down here, 7 steps. Through this 7 steps, we can analyze, we can identify the cause of the problem and the proper workflow. We can correct it. The successful application of the determination of the root cause should ultimately result in the elimination of the problem. So the step 1 is identify the problem. Step 2, select team. Step 3, collect data. Step 4, identify possible factors and identify the root cause. 6, define and implement an action plan. The step 7, that is monitoring and assessing the result. That is root cause analysis. And when should the root cause analysis be performed? When human errors occur during a workflow process, when performance is below standard, when equipment failures or adverse events occur during the certain work process. These are the main stages we are doing root cause analysis. And the last aspect is joint commission, mission and NPSG, that is National Patient Safety Goals. For that also, I am moving to the Google. The National patient safety goals, no joint commission. So here you can search. They're providing the 2022 patient safety goals. They are clearly given, and accreditation and certification also we can see. Here also for quality improvement tools and some certification courses they are providing. Joint Commission, 2022 National Patient Safety Goals. We can see the links, ambulatory healthcare chapter, assisted living community chapter, behavioral healthcare, human services and laboratory nursing care center chapter, laboratory chapter, everything we can clearly see. So that's about the qualities in improvement and methodology. I think all of you clear. Quality comes not from inspection, but from improvement of the production process by adverse. Hello all. That's about the important tools for improving the quality in healthcare. Any questions? Madam?
Yes, ma'am. Yes, ma'am. Thank you so much, ma'am, for sharing your ideas and providing a wonderful lecture. Any questions from the audience? Any questions from the audience?
Is it clear?
Yes, ma'am. Thank you so much, ma'am.
Thank you all. Thank you once again, the Society for Nursing Practices. Hope I have covered the important tools using for quality improvement. Thank you all.
Thank you, ma'am. Thank you. I would like to update for the upcoming nursing webinars. Srimati Radhika Bhai Meghe Memorial College of Nursing, Datta Meghe Institute of Medical Science Association with Society for Nursing Practices organized a national level webinar on the view of celebrating World Breastfeeding Week 2022. A webinar on Step Up for Breastfeeding, Educate and Support is held on 5th August 2022 as an online event. I welcome you all to participate in the national level e-poster competition on the theme Step Up for Breastfeeding, Educate and Support. Best of the posters will be certified and rewarded. Use this great opportunity to showcase your creativity. For registration and detailed contacts, you can contact on 934-5529045 or drop a mail at nursing@bioleagues.com. Please note down the number and get regular updates. I repeat the contact details. Call or WhatsApp to 934-5529045 or drop a mail to nursing@bioleagues.com. Update for the upcoming nursing conference. 4th International Conference on Nursing Science and Healthcare is the global nursing event, has been rescheduled on 1st and 2nd December 2022 in Kuala Lumpur, Malaysia. Online event, and it is a 2-day event where you can witness keynote speaker sessions and paper presentation. For the registration details and contact, you can contact on 934-5529045 or drop a mail to nursing@bioleagues.com. I repeat the contact details, 934-5529045 or drop a mail to nursing@bioleagues.com. Join now and be a part of a grand nursing event. Once again, I thank our expert speakers for lending their time to impart their knowledge on the quality improvement. I would like to thank our beloved delegates who actively participate in the webinar. Certificate downloading links will be posted in the chat box. and also mail to you where you can log in your account and download your certificate. Details of downloading the certificates: sign into your SFN account, SNFP account. If you are a new member, sign up. Click on sign up, enter your email, and create an alphanumeric password. You will be getting the OTP to your email. Enter your OTP in the SNFNP page. Using that, kindly sign into your account. After you sign in, on the left side of the menu, click on Certificate and Rewards. Then click over the Quality Improvement in Healthcare System. Download download, enter your name and click Download it. Thank you, and I would wish each and everyone a great day. Thank you so much, everyone. Thank you.
Thank you, ma'am.